next year. So when I was talking about that growth, here's one example. Kathryn is known by many of her peers as a thought leader in psychedelic medicine and a subject matter expert in ketamine therapies. Ladies and gentlemen, please join me in welcoming Kathryn Walker to the stage.
Thank you guys, happy to be here today. What I want to do with this is kind of make it interactive. So the word psychedelics is a big word. It's a big term. It's going to be a huge part of our market coming up in the next few years. They're expecting that it's probably going to be around $1 trillion market with psychedelics. So if you know the 1970s piece with psychedelics to where Nixon kind of made a whole abstinence piece across the United States, that's probably not going to exist much longer. There's a lot of people too across the United States and across the world that are really looking at psychedelics, yes, but then also with ketamine infusions. So ketamine, if you know ketamine, if you're in the addiction space, you've probably heard of ketamine. Ketamine's been around since 1970. It's an approved dissociative anesthetic, so it's the only drug that's actually in that class. But they're seeing that it has several similar mechanisms of action as the other psychedelics. So when I say the term psychedelic, I'm talking about MDMA, which is also known as ecstasy, psilocybin, which is magic mushrooms, LSD, ibogaine, ayahuasca, all these different pieces that actually change the setting of the brain. So the exciting piece in this, because a lot of people, they're just like, no, I'm not going there, I'm not doing this, I'm not listening to this. It's some of the best data that we've ever seen in behavioral health. It's the strongest data that we've ever seen in behavioral health. So with ketamine specifically, it was in the late 1990s at Yale University. They were actually looking at rodents. They were trying to make the little guy schizophrenic. They were giving these rodents huge doses of ketamine to try to make it hallucinogenic. And what they noticed was the rodents started becoming less depressed. So it was a complete accidental finding with ketamine to actually show that it was breaking the cycle of what the brain's doing. So now we're looking at psychedelics, that psychedelics can actually put the brain in a neutral space. It can disconnect the emotions from the object and allows the brain a second chance to get on a different path. So our brains don't understand right from wrong, or good from bad. Our brains just want us to survive, period. So you can be surviving in heavenly conditions or hellacious conditions. Your brain doesn't care as long as you're here. So when you really talk to people about mental health and mental illness, you'll see the pattern didn't happen in one day. The pattern got stronger over time. So when I'm talking to people about this, I've been maybe in 10,000 ketamine infusions. I can predict it pretty well now. It's a neurologic pattern. Mental health as we know it before psychedelics is very theoretical. But now with psychedelics, we're seeing that there's CAT scans, there's MRIs, there's actually inflammatory markers we can draw in the blood that's showing that ketamine and psychedelics are decreasing the inflammation. Not only the brain, but the entire body. So this is going to be a huge market. We've proven that mental health is directly coexists with pain. So we're seeing that psychedelics are also going to address pain. And it's something that they don't have to take every day. So for someone to understand this, that we can break a cycle, it can be episodic, it's a huge value-based model. It's going to change the whole world of healthcare. We have data from 2018 with ketamine infusions, and our data shows that we're 84 to 87% effective with ketamine, with breaking the cycle, with showing, you guys are in the last lecture, statistical significance with all of our individuals. The youngest that we've taken care of is 12. She had coexisting homicidality and suicidality. We actually got her back into school. The oldest that we've taken care of is 90. She lost her husband after 72 years, complex grief. So when you see people who are getting stuck, or if they're ruminating and they can't get things off their mind, or they've tried to kill themselves, or they have insomnia and they just can't sleep anymore, this is going to be the path. So I invite all of you, because I could talk literally for about 36 days on this. I'm fascinated by it. I am, a provider, we'll see that in a second. But then also, if you have questions, ask the questions. The microphone's there. Or do a shout out. I'm happy to answer it. I know this is brand new for some, and some people may be way more, professional than I am in this piece, but if I don't know the answer, I'll try to find it. But this is a market, like I said, it's going to be huge, and you all should listen because this is huge revenue potential. And then, like Paul was saying, we actually have an open financing right now. As Paul was saying, these are the clinics this is the behavioral model people need to start getting into because it's going to be huge. We do have a VA contract with Revitalist. So the VA actually has national protocols that they cover with us for ketamine. So they're providing the ketamine infusions for our veterans and covering that 100%. So that's huge. They've already made the path for us, and now we just have to take that to commercial payers and get that going to where we can have civilians be helped as well, because they deserve just as much as our veterans. So we're still trying to figure out what I am. I guess I get bored in life easy, so I created this company, Revitalist, back in 2018. I started working in the hospital system when I was 16, so I've been there for 22 years-ish. I was an ICU nurse for about 10 years, and then I became an anesthesia provider for about 12-ish years. And then I got tired of people telling me that I was an anesthesia provider and a nurse. I didn't know anything about mental health, so I went back and got my second degree as a psychiatry provider. So I'm a prescriber for both medical and behavioral now. So what we're going to talk about is we're going to review the science of psychedelics, talk about the availability in the United States. We're going to review candidates for the treatment based on current evidence-based data, and then talk about the environmental factors of consideration. So there's a lot of words on some of these slides, but I wanted to put them up here because I thought that they had great significance. When people tell me, so I actually lost my job when I was at the hospital system. When I was practicing anesthesia, I opened up the clinic. They told me you can choose. You either work at the hospital or you can get involved in voodoo medicine. So I chose voodoo medicine. And it's interesting now, because actually the guy gave me that option. We treated his son for addiction about 3 weeks ago. So it's interesting how the minds change. But you can see, so like I mentioned earlier, Yale University they were the ones who made the accidental discovery with ketamine. They have great data out there. They have great videos. They have one of my favorite videos out there. But Yale's very involved. Johns Hopkins, hugely involved. The FDA, they're talking about with MDMA, which is ecstasy. And then Duke just recently opened their Center for Psychedelic Science. So you can see these big names here. They're involved in it because they see the data. There was someone I was actually speaking to who injected the brains of rodents in Canada. They have a rodent lab there. And they actually showed that it was reversing the plaques, the beta amyloid plaques for Alzheimer's in the brain. So, so we're seeing mental health, we're seeing pain, but then there's also neurodegenerative. So if you guys go to Google Scholar and you start looking up, I want to see if ketamine's doing something with Parkinson's. I want to see if it's doing something with MS or dementia or whatever else. Type it in, it'll come up. It's amazing to see. But I have these here because I wanted to show, right now ketamine's your real-time revenue. That's what we're seeing, especially with the VA. But then with the commercial payers, they pay maybe about 60%. They won't pay for ketamine specifically, but they'll pay for the services that are around that. So that's a big feat that we want to get through to get the commercial payers. But then also the FDA, they have been involved with this. So your two biggest guys here are going to be MDMA with PTSD more than likely. They're expecting it's going to go live with the insurers in 2024. Maybe sooner. It's in phase 3 trials, and they're having beautiful results with MDMA. But then also psilocybin. So if you're keeping up with that, some of the states have approved for psilocybin, Oregon, Colorado, and I've just heard today MDMA with Arizona. So these are all just new facets that are coming to the surface, and those are more so microdosing. So there's small doses called microdosing. There's larger doses called macrodosing. You can look at the macrodosing aspect as being more of an intervention. Do you have a question?
Is ketamine currently off-label for anything other than anesthesia?
It is, yeah. So ketamine's FDA approved. That's a great question. Ketamine's FDA approved as a dissociative anesthetic, and then it is used in an off-label capacity. There are some, I think it's Awaken, who's working on getting an additional indication for the ketamine piece. And they're actually looking at addiction specifically is what they're looking at with their results. There was great results in the American Journal of Psychiatry with Awaken. But it is in an off-label capacity. But when you look at off-label capacities, up to 80% of all behavioral health medicines are used in an off-label capacity. So when we hear that, people are like, well, I don't want to refer them because it's used in off-label capacity. I'm like, well, 80% of your drugs that you're referring to us are also used that way. You know, like the number one drug that we use right now for PTSD is blood pressure medicine. So it's social acceptance is what we're working on, you know, and now they're starting to compare psychedelics to alcohol. And they're saying actually psychedelics are safer than alcohol. But we all have seen that alcohol is socially accepted, so we drink it, and you know, and so we do. So yeah, it's the taboo, lack of knowledge for all of us. I thought I was pretty smart. I've been in school for like 11, 12 years with college stuff. And I thought I was pretty smart, but then when I got out and I saw what I saw, I was appalled about how ignorant and dumb I was. Because I was sitting with clients who had 9 providers. And I know how to work with every one of the providers, but I said, who's advocating for you? And nobody was. Nobody speaks to people, right? I thought psychiatrists spoke to therapists and therapists spoke to psychiatrists, but neither of them respect each other. So my piece, fortunately as a nurse in a level 1 trauma for a long time, I can sit in the middle and navigate this stuff. So I built my company off of need. So we have underserved populations, veterans, first responders, adolescents, and athletes as well. And we're losing all those people. We don't know how to speak on their level necessarily, so that's something that my team has worked on, is really trying to increase the communication with them. But then also, I've built some curriculums. We have a global curriculum that's going to come out. And the curriculums are based on education. So I was telling one of the guys earlier, if you can increase your emotional intelligence, it decreases your chances of suicidality, it decreases your chances of homicidality, and this is something that we have to work on from a young age, not when I've tried to hit myself 3 times. Okay, well now we can treat you. It's like, no, just like, let's wait. If they start sleeping badly because they can't get something off their mind, let's think that that's probably a high risk factor to lead to mental illness. So that's what we're working on with a lot of these, and we do passively work with Johns Hopkins. So these are words that you guys are going to start seeing if you haven't seen them yet. And this talks a lot about the way the brain works, right? A lot of people can't understand what I'm telling them sometimes, especially if they're ignorant in this field. But once you see it, you can't unsee it. So when you're looking at addiction specifically, and mental health, when you're looking at addiction specifically, there's something called the default mode network. It's basically your brain's pattern system. So our brains, growing up, we like positive action creates a positive reward, negative action creates a negative reward, and it's a one-to-one. What happens over time, if you've spoken with people who've had addictions or in recovery from addictions, they don't understand why they made that action, because they feel horrible about it afterwards. They felt good for a second, and then they feel horrible about it. And what the brain's done is the brain has taken a negative action and caused a positive reward. But then you get this shame cycle, right? So it's this cycle that people with addiction are constantly going through. But what psychedelics do, and what ketamine does, and I smile over this, and because some people have not liked me when I'm like, that's amazing. They're like, no, that's not what I was wanting. I was like, no, but that's so cool. So what happens with psychedelics and ketamine is they make the one-to-one correlation come back. So they make a negative action create a negative reward, or a positive action create a positive reward. So I had one lady, she came to me, horrible depression, and she'd been a 2-pack-a-day smoker for 40 years. She comes up to me, she goes, I quit smoking. I'm like, oh, that's wonderful. And she's like, and I don't even want a cigarette. I said, that's fantastic. And she said, no. I was here for my depression. I enjoyed smoking. Now when I go smoke, I throw up. So I was like smiling at her, and she didn't like it. And she knew nothing about nicotine withdrawal either. So I'm sure she felt horrible, but we got her all fixed up. But there was that piece, and then I had somebody too who was taking Xanax one time, same thing. And they're like, I get around it and I throw up. I get sick. It's almost like Antabuse, if you all know Antabuse, which is kind of a difficult drug. But that's what psychedelics do, is they decrease the emotional connection to the object, and then they put the appropriate reward to it. Because everybody knows it's bad. It's bad if I shoot up heroin IV. I know it's bad, but it makes me feel good for a second. And that's the neat thing with psychedelics, is psychedelics are showing that it's completely disconnecting that, and it's putting the brain back on track to where the brain recognizes that it's bad for them, and they have negative consequences. So, functional connectivity, that's a big one. So they've shown that the brain duplicates what it knows. So the way I kind of explain that to people is, everyone believes in muscle memory, right? The whole world, we're all like, oh yeah, it's muscle memory. Somehow we just got stuck on physical. We forgot behavioral exists, or we don't even think that I guess it ever existed. But your muscles don't have memory. They're just fibers that contract, they just engage with each other. It's your brain that remembers the muscle. Your brain also remembers behavioral. So if we've treated maybe like 15 active duty police officers now, and they just get to the point where they scan and they scan and they scan and they can't sleep, they can't sleep, they can't sleep. And I'm like, was it this bad a year ago? Oh no, it wasn't this bad a year ago. So you can go back, you can backtrack it to when it started. Your brain duplicates what it knows, and when it duplicates what it knows, it does its own thing. So PTSD, depression, we're seeing that a lot of that is neuroinflammation. So when you have an inflamed brain, and it's duplicating all these pathways, they're damaged. They're damaged pathways. And you can actually see that on some really cool PET scans out there. Type in ketamine and PET scans. There's a lot of really cool different types of temperatures with the neuroconnectivity. But they've proven with ketamine, I've not looked at it specifically for psychedelics, but I'm sure she's the same. They've proven it with ketamine. The ketamine increases the connectivity of the brain. So you have all your pathways that connect with each other, but then you can actually see new growth on these pathways after one ketamine infusion. And I'll tell you, one ketamine infusion is not going to do that. It's not going to heal people. They come in, they want to do one. It's not going to heal them that way. It's the start. It's a cycle. So typically with ketamine, there's an induction period, and then there's a maintenance period. So you have an intervention, and then you have maintenance, right? So your intervention period with ketamine specifically is usually 6 treatments over the course of 2 to 3 weeks. People who have more complex trauma, they need to be more 3-week-ish. People who can't get out of bed, they need to be more 2-week-ish. So you kind of listen, but they eventually all fall into a pattern. So connectivity, they've proven. So if you guys are involved in the ECT world, what we do with ECT, the electroconvulsive shock therapy, which I used to do anesthesia for that. We shock people, we make them seize, we kill parts of their brain, expecting their brain's going to regenerate, right? Ketamine actually shows that it just improves the regeneration. Nothing dies. It decreases the inflammation and it increases the connectivity because it's making new pathways. You're going to see the term psychedelic-assisted psychotherapy. That's something that I personally feel is necessary. I'll tell you why. Personal experience. I've had a lot of personal experiences, so should you want to go down this path, you can always talk to me because I've created a lot of wills and they've not been easy. So learn from my experience and ignorance instead of doing it yourself. But I opened the clinic. It was me and another anesthesia provider at the time, and we would do infusions. I had one guy who came in with him and his sister and his friend. His sister was a nurse. And we did his consult. Came in with a hoodie on. He was emaciated. Did his consult. And he didn't really participate in the conversation. And I said, yeah, they told me his whole story. So his wife was a university professor. She shot herself 6 years prior. And he's been drinking and all these different pieces. And so I went through his whole history. I said, yeah, I think you'd be a candidate for ketamine, but let me request your records to make sure he's good. And the sister pulled me to the side and she said, if you don't help him today, he's gonna go kill himself. He's got a gun, he won't tell us where it is, he's got his plan. And I was like, well, it's kind of a predicament. So I called his psychiatrist and I said, hey, I've got Jim here with me. Do you think he's a candidate for ketamine? And he said, yes. And you need to work quickly. I've been seeing him for 7 years. Okay. Good thing I'm kind of trained in the high acuity piece. So take Jim in the back. At this time, we had no therapist. It was just me. And you'll see ketamine clinics, a lot of times they don't believe in therapy. They believe in the anti-inflammatory piece, and I do too. But they don't believe in the therapy aspect. But with this piece, took Jim back there, started his infusion. And he was so severe. I knew he was severe. He was so severe, he had something called transference of his dead wife on me. So what he didn't allow himself to do after she killed herself was to get angry with her, which is part of the, the 7 levels of acceptance and all that stuff. So he got angry with me. Unfortunately, people on ketamine, they're not as intimidating at the time because they're drugged, right? I mean, I could have controlled him a little bit more, but I let him, I was sitting there with him, and I became his wife, and he could see my brain, my blood, he could smell, I had a headband on, he actually ripped my headband off, he could smell his dead wife with me. And then, and he went through everything. But I would reorient him, and he'd be right there with me, and literally in a second, he'd blink his eyes, and he'd go right back to her. He was so severe. But fortunately for me, I had a therapist come in the week before who I did a consult with. And I was like, yeah, you're a candidate to take this. And he's like, no, I don't want ketamine. I just want to help you if you need help. So I was like, okay, whatever. I'm not going to need a therapist. I know what I'm doing. So after I got shook, and the guy saw the blood and brains on my head, I called the therapist and I said, hey, were you still interested in helping? So he came and actually worked for me for about 2 years. And so we actually offer therapy during the session of ketamine. So they go into this neutral pattern. And if you talk to therapists, they try to get people to go into the neutrality all the time. That's when talk therapy really becomes effective. Ketamine acts as a stimulant to do that, or a catalyst to do that, I guess. And it puts people in the neutral setting to where it's about 6 months of effective therapy at one time. So this guy, yeah, he's completely, this is well over 4 years ago that I treated him, and he doesn't come back for ketamine. He used to come back once a year right before his wife died, but he doesn't come back anymore. He's remarried, he rides his Harleys across the country, and he's good. But we do have therapists or coaches or whomever, someone who's trained that I feel comfortable enough that can actually handle this kind of situation, environment. And that's another piece, the environment is high acuity. So if you're not used to trauma, if you're not used to hearing about rapes, if you're not used to hearing about acute loss or death or shootings, or seeing self-inflicted gunshot wounds, then you need to train your staff or not be in the rooms. That's one of my biggest pieces with this too, is like, I think providers are strong enough to hear this and to see this and to be in it, but it's a completely new discipline, completely new discipline. They tried to put me in a pain clinic in the state of Tennessee. They tried to close my clinic, and they said, ketamine needs to only be in pain clinics. I said, you're creating a bomb. I had to go down in front of 80 physicians and tell them, this is not a good idea. Do not put a mental health patient who's suicidal next to somebody who has a handful of vortex. So I won that argument. But when people are trying to put this into a bubble or just add it as an additional service line, it's not going to work. You've got to train these people on how to do this. And I've been around tons of death, and I'm very well equipped for that. But we've got to be able to understand when to walk away from clients, because people get so codependent with clients too. I'm sure you all see that in the field that you're in right now. But it's something that you just have to be aware of. And if people say, yeah, I've got this, it's easy, expect some repercussion from that later down the line. So here's a couple other words, and I won't go over these too specifically, but the amygdala, you got synaptogenesis, neuroplasticity, salience network, and then your central executive network. Basically what those terms say is that there's parts of our brains that process differently. And if we can get them to process effectively, then you do better. Your clients get better. So one thing I like to tell people, you got short-term memory, you got long-term memory. Short-term memory has emotions attached to them. That's your PTSD, that's your teenagers that are ruminating, that can't get things off their mind. And it loops, it constantly loops, and they don't know how to stop it. So they've actually proven through the salience network that that's a weakness of the structural components of your brain if you ruminate. Every time you break a rumination, it's like lifting a weight in your brain. So what ketamine does, and psychedelics, is it brings up those short-term memory pieces with the emotions that are attached to the objects, disconnects them. So when you're sitting there with a therapist, say if I was upset or crying, worse than that. Say if I got raped and I couldn't get it off my mind, right? What happens with ketamine and psychedelics is the rape comes up, I don't feel the emotions attached to it, I can talk about it, and the pieces that I'm talking about at that time are the pieces that my subconscious held on to that actually allowed me to survive that event. So you're able to talk about that piece. What happens is the amygdala helps to process it, takes it from short-term memory to long-term memory. In your long-term memory, you have no emotions attached to it. That's why you talk to people who've had acute loss and they can talk about it very, very well. They've processed that. You see people who want to cry over acute loss and they just can't talk about it. They've never processed it effectively. And that leads to a lot of the symptomatology that's worse. So these are your biggest pieces right here for psychedelic medicine that you'll see come up. Depression, anxiety, PTSD, palliative care, and addiction. With the addiction piece, there's been a lot of antagonizing views with people because you see people get addicted to ketamine. You see people get addicted somewhat, not really, but kind of, I guess, to the LSD pieces and all those things. But if you really understand addiction, the thing about psychedelics, they don't act like our other addictive substances in the brain. So if you have receptors in the brain, right, there's something called upregulation. So picture you have a light switch, one light switch. If I take ketamine, I still have one light switch. If I take psilocybin, I still have one light switch. If I take heroin, I grow 2 light switches. That's true addiction. You get more receptors in your brain that need more substance. So you're feeding your brain. Ketamine doesn't do that. It actually helps with even something called detox. So you can actually detox people and decrease all those light switches of the brain that allows the brain to not be effectively addicted to the substance anymore. But then you've got to work on all the psychological and the physiological aspects. So with ketamine specifically, people who use the drug get abused, or who abuse the drug, and a lot of times they'll snort like 3,000 milligrams, which is a crazy dose. They get used to disconnecting from where they're at, which is kind of what we do with opioids and such. But there's not a physical addiction in the brain, it's a psychological addiction. So you do have to work on that. Palliative care, they use it in palliative care a lot, ketamine specifically. It's most hospice people use ketamine. But they do that more so for pain, and then also when people are dying, they gurgle sometimes with their saliva, and ketamine helps with that to decrease that, so it's not as hard on the family members. So this is big, this is huge. Alcoholism with ketamine. So if you look in the American Journal of Psychiatry, they've actually produced this. And what it shows they had 4 groups here. And basically what it shows is people who had significant alcoholism, who had elevation even in their liver enzymes, showed their liver wasn't working well, which is actually a contraindication for ketamine. They actually showed that they gave these people ketamine. They were able to improve the length of time that they were sober, which gave them more time to intervene effectively on trying to keep them sober. So this company's Awaken. The University of Exeter is where they're kind of based out of. There's a really cool guy named David Nutt who works with them specifically, but he's a big addiction researcher. But this is the first study that came out to show that ketamine is actually treating this. So when you're talking about the FDA indications, this is what Awaken's going for, is trying to get this as an indication. And we're actually partnered with them to help to execute their protocols with alcoholism in the United States as well. So it's they're calling it relapse prevention. So this is fascinating. So here's a piece too. So this is my clinic on the left side, it's like and then here's pieces on the right side of other places. So when you look at ketamine, and then Paul and his team were talking earlier about the Centers of Excellence, which I love. I love Centers of Excellence, I love standardized care. I love all of this because when I got out in the behavioral health world, and I saw people were struggling with suicidality, and they would go to a therapist, my ignorance with a therapist was I thought therapists were supposed to hug me and tell me I'm beautiful and help me to go along my way. But then I learned that therapists actually can impose their own values on you and you have nothing to say about it, right? So the therapy world is very theoretical, which is great if it works for you. But it's great if it's horrible if it doesn't. It's unethical. So I go to, I've had people, I had a woman whose husband beat her. She's been in the hospital 5 times. She went to a therapist to get help. The therapist told her that if she divorced him, she'd go to hell. She wasn't a Christian, this lady wasn't. She's trying to find a therapist. So the therapist is telling her Bible, Bible verses about going to hell when her husband's trying to kill her. I've had people who have tried to do conversion therapy on those who have spit in the kid's face. It was a kid who was a transgender, who was a girl to guy, but spit in the face, told him to go to this retreat, which they did, which the family trusted, in Africa, and they actually beat the child with chains. The child ran away. Parents came and picked him up like 3 weeks later. I mean, there's so much out there, guys, that we don't know that's actually going on, and it's accepted. So my background, and I always talk about cardiac anesthesia. I did cardiac anesthesia for a long time. My background is, or my piece of all of this is, if you go to a company like mine, Revitalist, and say there's one in Maine, say there's one in California, then you're going to know what we stand for, and when you walk in. Same way with heart surgery. The heart surgeons have a standardized care to where if you go to Maine, you go to California, you're expecting similar results because they have data that they actually go off of that's evidence-based. So that's what we want. This is what psychedelics are going to do. They're going to make it all evidence-based. You're going to see value-based care with beautiful data. And the neat thing too, with Johns Hopkins and Yale and all of them, looking at ketamine with all this research, it's the first unbiased data in the entire world. Nobody owns ketamine. They can't. It's too old. So when you go out and you're making new drugs, you own the royalties for 20 years. Ketamine was FDA created in 1970. It's 52 years old. Nobody can own it. So you're getting your biggest institutions that have the best data. So let me say something here real quick. So this is our room on the left. We make it it's called an enriched environment. We make it very warm, very comfortable. Turn the lights off kind of to where it's more mood lighting because people get photosensitivity with that. You see other people on the right side, the lady on the right side. Some people like to have headphones. Some people like to have the masks on. Some people don't touch them. Other people, well, like us, we actually have them sit in during the infusions, which we think is huge. We feel like we have better results because of that. I know at Johns Hopkins, when they're doing a lot of psilocybin trials, they usually spend about 40 hours to develop rapport, just talk therapy. Then they'll do a macro dose, big dose of psilocybin, and they'll let the person sit there by themselves for like 4 to 6 hours. Then they do integrative therapy after that. So you're going to hear about 3 levels of therapy with psychedelics. You're going to hear about prep, intra, and then integrative. So those are all big pieces that people are really pushing for. The bottom right side looks more like an MDMA area. So they'll do that kind of with the FDA trials. They'll actually lay people on the couch. And they'll usually have 2 therapists in there with them that sit with them the entire time. They have 2 therapists because I think it usually takes 6 to 8 hours to do 1 MDMA session. And then the therapist will hand off, like if one has to go to the restroom and vice versa. But they just sit there with them, and if they need them, they let them. So this is Rosalind Watts, who's a lady who's pretty popular in this space. There's a lot of people that are becoming more popular. There's a guy named Michael Pollan, How to Change Your Mind. There's another guy named Paul Stamets with Fantastic Fungi. And then there's a guy named Rick Doblin. And Rick Doblin is pretty interesting. He's a physician. He actually created maps for the FDA back in 1985. So this data's been going on for almost 35 years. And people all the time say, well, there's not enough data. It's not been around long enough. It's been around long enough, and there's going to be more data than any of us ever knew about. What Rosalind says here is, although many of us think of psychedelics as dangerous drugs, it's time for a rethink. They are non-toxic, non-addictive, have very few side effects, and can potentially offer relief for people suffering from a range of psychological difficulties. So when you see this, you're going to hear, it needs to be plant-based, it needs to be plant-based, it needs to be plant-based. I don't disagree with that. But we also need to hear that plant-based medicines are also dangerous. You got an effective dose and a lethal dose. So heroin is plant-based. sort of, opium, right? Opium is its parent plant. So that's natural. Digoxin, which is it's a heart drug, it's natural. So do we want to push natural versus synthetics? I don't know. I'm in the middle on both of those. I just want people to be safe and ethically cared for. But with this piece, you're going to see like Oregon. I know Oregon for a fact, they have actually received approval not to allow synthetic psilocybin in the state. So it's going to have to be all organic psilocybin. And then the state of Oregon has actually taken applications starting in early 2023 for labs to start producing psilocybin that are FDA approved. So this is going to be a very big piece, and I think all of you should consider putting it, or implementing this service line into your companies. Even the hospital systems. So I've spoken to a lot of hospital systems. So what's dragging down the hospital world right now is your ER visits and mental health care. And you also got your inpatient aspects as well. So if you're able to bring somebody into the ER, actually assess their risk, give them a ketamine infusion, break the cycle of what they're doing, you're breaking the circle that's sucking out the system. So, even hospitals, need to be involved with this. Yes?
I have a residential treatment center. A couple of years ago, I went to some of my in-network insurance partners and trying to find out if I could get reimbursed for this and if they would allow it. And I was told not only would I not get reimbursed, but I risked my in-network status if I provided that, as it was not considered best practice.
Yeah.
Where are we on that?
Yeah, it's still getting there. They'll most of the time tell you now it's investigational still. But companies like Paul's earlier, who was talking, when you have I think we've given maybe 50,000 infusions now. That one of the researchers from the FDA told us we have the largest ketamine database in the country. But basically, we just need to take the data to them specifically. Because, they can threaten you all day long with that. And that's what we do, right? We put the fear of God in everybody in the United States, especially your provider. We're going to send you to prison if you do this, or we're going to take this away. The piece of it is, they're trying to tell you ethically that's wrong. But what I want to do is take the data and show them ethically it's wrong if they don't. Because, the 12-year-old who had coexisting homicidality, suicidality, who's kicked out of school, who got back into school, and she's back into school 2.5 years later, and she's not had suicidal ideations, how can you say that that's not the path that you should take, So with COVID, right? There's more people dying right now with mental health concerns than died with COVID across the world. And the FDA fast-tracked vaccine. It's like, we need to fast-track ketamine, guys, because the leading cause of death right now, for the kids, it's like 10 to 14 is your second leading cause is suicide. I think it's 25 to 34 as well. It might be the #1 leading cause of death is suicide. So when the insurers say that, what we need to do is make a database that states, no, and this is why. And we just push it across the board. I don't know if you can tell, I could probably argue this pretty well with the insurer, and I'd love to take that on. But the piece of it too is you could say, well, the VA is covering it. The VA has national protocols for it. The contract that I received in 2018, I only received it because they denied me 9 times. Because when you're an anesthesia provider and you say, I'm doing mental health in the outpatient community, they're like, I don't know what to do with you. So they just kept denying me. And then they said, we have too many of you. And then finally, I had one of the bigger administrators at the VA. He said, you're the only practice in the state of Tennessee that's doing this. And he wrote the contract for me specifically, and he got the higher-ups to sign it off. So what we can do with that contract, actually, with the veteran piece, we can duplicate that contract across all 50 states. So we can do MSAs, we can do management service agreements with existing establishments, and we can start putting that into the establishments to where we can allow those establishments to actually start caring for veterans. And then you start comparing your data that way and showing them how much money you're saving them. Because you're saving tons amount of money. I've had people who have failed ECT, been inpatient 7 times. This one lady, unfortunately, she was like, well, honey, I'm kind of on my last rope. And I was like, okay, well, when did you start antidepressants? She's like, 1982. And I'm like, well, can you not see your strength? You've been doing this for almost 40 years and you're just now on your last leg, and that's the piece of it. It's like, if we can get up here, if they don't have to meet me like right before they die, right? That's the only time you can get to meet me in the anesthesia world is I get called to the floor because somebody's trying to die and nobody else can help them. So then, okay, well, here we are. Why don't you put this skill set way up here at the front And we intervene effectively, and we decrease the cost to all these individuals, and then we save the entire healthcare system. So yeah, no, I would, if somebody said that to you specifically, one, I think the VA piece would be a huge argumentative angle. But then also, I would find data from Yale, I would find data from Johns Hopkins, and you can pull all those. Yale's biggest guy is a guy named Gerard Senecora. He's over the medical school as well, but Gerard's a big proponent, and there's a lot of advocates out there. So that's something that we really need to address. We did used to bill for ketamine, specifically the IV with the commercial payers. They gave us prior authorization, and they came back like 3 years later and they said, yeah, it's still investigational, and they just take all the money back, you know. So we stopped billing for those specifically. We only bill for the veteran piece until we can get those established. But yeah, I know that they took people's license in Michigan over Lyme disease. It was a physician who actually diagnosed Lyme disease, and they took his license. And it's interesting because Europe's had a vaccine for Lyme disease for 30 years. You know, so it's like, what are we doing? It's all messed up. But I gotta tell you, when you go into the outpatient community and you start asking questions and you know what questions to ask, you'll realize, does anybody have any clue what's going on right now? Because I don't think a lot of them do. So they need some guidance. So yeah, it's a great community to give some additional guidance.
How do you compare ketamine to Spravato?
That's a good question, yeah. Spravato, so we're approved with Spravato as well. So Spravato is your S-ketamine, right? Drugs have two right and left side. Your Spravato is your left side of the ketamine, so it's not as potent and it's longer acting. Lots of money in Spravato. Janssen still's working on the business model. And with that piece, there's a lot of changes. So like in Knoxville, where I am primarily, there were like 30 people who started out in Spravato. Now there's only, my God, because it was like, here's a hoop, here's a jump, here's a hoop, here's a jump. Nope, we're not gonna do it this way, we're gonna do it this way. So it's kind of hellacious to start the Spravato process, I'll tell you that. The efficacy of Spravato is about 20 to 40%. They're still working on those pieces as well. They'll tell you that the route of administration, which is nasal, is between 0 and 44%. So the way I see Spravato, the way I've talked to Johnson & Johnson and Janssen about Spravato, I see it being a complementary medication with the interventions with ketamine. And they should go hand in hand. Some people do very well with ketamine, or with Spravato specifically. I would not use Spravato for acute suicidality, because it takes about 2 weeks to really get a good effect that you can start seeing. Ketamine with suicidality is like one dose is about 98% effective to break that suicidality. So you want to go within, if somebody comes in, they're suicidal, you want to go in with your strongest intervention possible. But yeah, I do believe in Spravato for sure.
Katie, we're actually gonna move on to our next speaker, but I know we have a lot of questions, so you'll be around, right?
I will be around, yep.
So, ladies and gentlemen, let's give Kathryn Walker a round of applause. So again, some really fascinating topics, and like I said, I know a lot of you have some questions, and